Hello friends, I am Dr. Mayank Massand from Medanta Hospital, Indore, and I am functioning over here as Senior Consultant Anesthesiology and Critical Care. In the next 45 minutes, we are going to discuss about neuromuscular monitoring. Neuromuscular monitoring, as you can see, has become one of the most integral part of our operation theaters. Why it has become an integral part of our operation theaters? Because the variety of age group that we are dealing with and the comorbidities that the patient are having nowadays, and they land up into operation theaters, actually pursue us to use this tool in our operation theaters, and it is an extremely useful tool to prevent us from deadly complications following anesthesia. Now, why do we need a proper neuromuscular monitoring? We need a neuromuscular monitoring because we have got a very narrow therapeutic window. And as I said, the individuals have variable response to muscle relaxants depending upon their properties. Like there is no detectable block with a non-depolarizing muscle relaxant until and unless 85 to 90% of the receptors are occupied. Secondly, there is complete paralysis only when 90 to 95% of the receptors are occupied by the non-depolarizing muscle relaxant. Which receptors? Nicotinic acetylcholine receptors, which are present at the synaptic cleft. This is the level of margin of safety that we are having nowadays in the body. In spite of using clinical criteria for reversal of our non-depolarizing muscle relaxant block, 42% of the patients go into inadequate reversal, leading into ventilatory insufficiency, hypoxemia, putting them back onto ventilatory support, sometimes aspiration because of vomiting and pulmonary infections. Now, what are the essential features of a peripheral nerve stimulation? The device should be battery powered. It should have constant current but variable voltage. Secondly, it should be capable of generating multiple patterns of stimulation like single twitch, double twitch, train of four, tetheric facilitation. Now, variable voltage is extremely important so that we can assess various muscle units at variable voltages. It should be capable of delivering square wave impulse, that is less than 0.5 millisecond duration or more than 0.1 millisecond duration. Now, other qualities or optional features are there should be a rheostat so that there should be an adjustable current output. There should be a polarity output indicator, positive and negative. High output capable up to delivering 80 to 100 milliamperes, and low output that is less than 5 milliampere sockets. There should be an audible signal like T, TO with each stimulus. Alarm, if we are applying the electrodes and there is greater resistance and impedance, it should be capable of giving an alarm. Secondly, if the leads are disconnected, it should be capable of delivering an alarm. Similarly, in the case of low battery, once the battery is losing its charge or is fully charged and we don't require to charge it anymore, there should be an indicator for that also. We should be ability, it should have an inherent formulation to calculate and display the fade ratio and percentage depression of a single twitch. Fade ratio we are going to discuss further. Now, which instruments are being used for that? The instruments that are being used for that are electrical stimulation, or we are using magnetic stimulation. Now, magnetic stimulation has got extreme disadvantages. It is bulky and heavy. We can't apply a train of 4 type of stimulation, and we can't go for supramaximal stimulation. And these advantages are it is less painful because it doesn't require any kind of physical contact. But for clinical purposes, the device that we are using are electrical based. See, this is the device that we are using. These are special electrodes in order to reduce the impedance of the skin. Silver and silver chloride electrodes. The distance between the two tips, the first is applied onto the proximal portion of the molar aspect of the wrist, and the second electrode is applied at such a distance that the center tip of these two electrodes are separated by a distance of 3 to 6 centimeters. Now, what are the features of neurostimulation? First of all, what is a nerve stimulator? A nerve stimulator is actually a battery powered device that delivers depolarizing current with the help of these electrodes. Okay, these are the two leads that are coming out of the device, getting attached over here, and with the help of a battery powered device, we deliver the current and we are able to assess the response of the hand, and we go ahead with this particular feature. The nerve stimulator, battery powered device that delivers depolarizing current to electrodes. Stimulus strength. What do you mean by that? Stimulus strength, that is, the depolarizing intensity, depends upon the duration. That means the pulse width and the intensity reaching the current nerve fibers. Now, what is pulse width? Pulse width. Pulse width means duration of individual impulse. We are giving one impulse. What is the duration? It should not exceed 0.5 milliseconds. Why? Because we will enter the refractory period of the nerve and there will be repetitive firing, right? It should be capable of generating a monophasic pulse width and a rectangular wave form. So the duration should be less than 0.5 millisecond to 0.1 millisecond. Current intensity 0 to 80 milliampere. It should be voltage generated, right? Number one. Resistance can decrease the current intensity. First of all, why the resistance increases? It is because of the impedance of the electrodes, the skin, underlying tissues. Hypothermia causes increase in the impedance, that means the resistance, and there will be some improper readings if we don't maintain the temperature of that particular area. Now, what is the threshold current? The lowest current to depolarize the most sensitive fibers and produce a detectable muscle response is the threshold current. Initial threshold stimulation, evoked tension, delivered current, and the lowest current, which is capable to depolarize the most sensitive fibers and produce a detectable muscle response, is the threshold current. Supramaximal current, 12 milliampere, 30 milliampere. What does that mean? 10 to 20% higher intensity than the current required to depolarize all muscle fibers in a nerve bundle. Okay? If suppose we have to require 12 milliamperes of current to depolarize all the muscle fibers in a particular muscle bundle, but we will give a current which is 10 to 20% higher than that 12 milliampere current, so that we can produce a detectable muscle response even in paralyzed muscle units. Submaximal current, only a fraction of the fiber of nerve bundle gets stimulated. Submaximal current is having an advantage over supramaximal current. That means it is less painful. Supramaximal current will be painful. So only in anesthetized patients we are giving supramaximal current. Now, what is stimulus frequency? The rate at which each impulse is repeated in cycles. Point 0.1 hertz, that means 10 seconds interval. 50 hertz stimulation, that is 50 seconds stimulation. So 10 seconds, if we are giving a stimulus after every 10 seconds, so it is 0.1 hertz is the stimulus frequency, because we are giving the stimulus after every 10 seconds. This you can see the graph. Initial threshold for stimulation 12 milliamperes, supra-maximal stimulation, that is 30 milliamperes. Now, what are the electrodes that we are using for that purpose? Surface electrodes. Surface electrodes you can see over here. These are the surface electrodes. Again, I specified distance 3 to 6 centimeters between the two centers. And needle electrodes. Needle electrodes not recommended nowadays. Why? Disadvantages are local irritation, there is nerve damage, there is repetitive firing. Why? Because we are going into the refractory period of the nerve, and there is direct muscle stimulation. So in spite of not having complete reversal, it will show a response. Surface electrodes, these are silver or silver chloride electrodes. We should not use normal ECG electrodes because they will always show false reading and they are having greater impedance. Now, there are special electrodes which are useful for neuromuscular transmission. We should be using only that. And what should be the diameter? 7 to 11 millimeters of the diameter. Monitoring sites. What are the monitoring sites to be used? They should have three features. First, easily accessible. Second, we should be able to quantify the muscle response, and there should be no direct muscle stimulation. That means if we are using the ulnar nerve, which is located on the medial aspect of the wrist, we should be able to assess the thumb response, which is located on the lateral aspect of the wrist. So the site of the nerve stimulation and the site of subsequent evaluation of the twitch response should be topographically distinct. This is the most important feature. They should be topographically distinct. Which are the nerve muscle units that we are using? Ulnar nerve with adductor pollicis muscle. Most commonly used, gold standard. Why? Easy accessibility for visual, tactile, as well as for objective mechanographic assessment. There is least chance of direct muscle stimulation, right? There is least chance of direct muscle stimulation. In the foot, we are using posterior tibial nerve and flexor hallucis brevis muscle, which will assess the great toe response. And facial nerve with the orbicularis oculi muscle just in front of the tragus, we are placing it over here, we are assessing it. This has got the highest chance of direct muscle stimulation. Why? Because it is present superficially over the forehead. Now, a few words about the adductor pollicis muscle. There is a different sensitivity of the laryngeal muscles as well as the diaphragmatic muscles when we are using them, train of four or any other muscle nerve stimulation in the nerve muscle unit of ulnar nerve with the adductor pollicis muscle. So we have to be careful even when you are using this to assess the reversal point to be given. First, dorsal interosseous muscle. It is the best muscle to assess the EMG response. And why the muscle? All these muscles, along with the laryngeal, the diaphragmatic, the vocal cord, why do they differ in their response? Why? Because the acetylcholine receptors that are present over the junctional cleft are of different density and they have got different sensitivity also. Difference in response because of fiber composition, blood flow, muscle temperature, number of neuromuscular junctions available, that is called as innervation ratio, and response artifacts can occur in the case of paretic limbs. So we have to be careful when we are using all these muscle stimulation to be very specific when we are using them. You can see over here, the extraocular muscles are most sensitive for determining the reversal. That's why we see the twitching of the eyebrows as the first response when the person is coming out. After that, pharyngeal, followed by masseter. Adductor pollicis is on the fourth level, and vocal cord and diaphragm. They are the most resistant to the reversal agents. So, this particular muscle group, when we are using for objective assessment, also the train of 4 should be less than zero point 0.4, or there should be a reversal. Then only we could assess that vocal cord and diaphragm now must be free of the effect of non-depolarizing muscle relaxant partially, and we can give the reversal agent to make them fully free and functional. This is a small table that is featuring the qualities of each and every type of current stimulus that can be applied with the help of a battery powered neuromuscular monitor. And we are going to talk about them one by one in detail. First of all, the pattern of stimulation is a single twitch stimulus. Single twitch stimulus was first devised specifically developed to monitor neuromuscular block at St. Thomas Hospital nerve stimulator. What is the mode of stimulation? Single current. 1 Hz, 2.1 Hz. Response is frequency dependent. What kind of current is used? Supramaximal current is used. Clinical application, it is used as a component of post-tetanic count. After post-tetanic facilitation, we give a single supramaximal stimulation to see the muscle response and the fade. It can be used for research purpose as a yardstick to assess the potency of drugs or other modes of stimulation. That means as a control. A single twitch is used as a control for other patterns of stimulation. And this is the only stimulation pattern that allows assessment of depolarizing block after succinyl choline. Now again coming to this table, what is the kind of strength that we are using? Supramaximal. Frequency 0.1 to 1 Hz. Pre-relaxant control, yes, we need it. Pain or stimulation, no, because after anesthetizing we are using it. Sensitivity of manual detection, not sensitive. Alteration of subsequent responses, we are not giving it, not altered. Interval between successive stimuli, we can use it after 5 seconds. Again, we can use a supramaximal stimulation. How much receptor occupancy it can detect? 75 to 90%. Sensitivity for detection of subtle block? No, it is not. It is not useful for detecting sensitive, for detecting subtle block. Monitoring of profound block, not useful. But when it is used with post-tetanic count, it becomes useful. See over here. When we are giving a non-depolarizing muscle relaxant, applying a single twitch, after 5 seconds, there is a fade response that is occurring. In a depolarizing block also, there is a fade response that is occurring. And then it is picking up. So, this is the only pattern of stimulation that is single twitch stimulation that is useful in assessment of a depolarizing neuromuscular blockade. Train of 4. Earlier associates introduced this. T4 by T1 response is assessed in it. It is the most commonly used method and it is inversely proportional to the degree of blockade. Okay, now let me show you by that. What do we mean? First, coming to the table. Supramaximal or submaximal current strength is used. We apply 4 stimuli, each separated by 0.5 milliseconds. So total is 2 Hertz. Pre-relaxant control, we don't need it. We are applying a control stimulus in which all the 4 heights will be same. Pain or stimulation may be there, may not be there, plus minus. Sensitivity of manual detection, visual or tactile, it is not sensitive between TOF ratio of 0.4 to 0.7. Alteration of subsequent responses, not altered. Interval between 2 hertz. After 12 seconds, we can again apply 4 stimuli. So interval between successive stimuli is 12 seconds. It can detect 70 to 90%. So it is somewhat sensitive. Sensitivity of detection of subtle block? Yes, it is sensitive. And monitoring of profound block? No, it will not be able to detect a profound block. Why? Because 70 to 90% occupancy detection only, not beyond 90%. Limitations are it overestimates recovery. That is, fade is accurate only if ratio is less than 0.4. So we require an objective monitoring. It doesn't monitor a depolarizing block. We never ever we are able to differentiate a deep level of blockade to give the reversal. Now we can see over here after 12 seconds we are using 4 stimulus. Over here these are the 4 stimulus. After 12 seconds again for when we are using a non-depolarizing block, there is a fade in response. Why? Because the acetylcholine is not getting bounded to the nicotinic acetylcholine receptors. They are getting occupied by non-depolarizing muscle relaxants. So we are calculating the T4 height by the T1 height. And the device is able to quantify it and give you the value. This is called as the TOF ratio. Over here, the size is decreasing of the subsequent stimulus, but the height is the same. You can see. So it is not at all useful in the case of a depolarizing block. Double burst stimulation, it was developed by Wibby and Mogensen and associates in 1989. So, and advantages are it is having better tactile evaluation than the train of 4. Okay. Disadvantages are still not useful to exclude residual paralysis corresponding to TOF ratio of 0.6 to 0.9. So it is less sensitive. Coming back to this table, double burst stimulation, supra or submaximal current, 3 impulses at 50 hertz each, repeated after 750 milliseconds. The second can be again 3 impulses or we can apply 2 impulses. So the ratio will be 3:3 or 3:2. Pre-relaxant control is not needed because we always apply a supramaximal current as a that we don't require as a current. Pair on stimulation, it will be there. Why? Because 50 hertz repetition is there and we are applying 3 impulses. Sensitivity of bandwidth detection, it is highly sensitive. Okay, highly sensitive. Then alteration of subsequent responses, not altered. Interval between successive stimuli is 12 to 15 seconds. Receptor occupancy 70 to 90%. Sensitivity of detection of subtle block, it is sensitive. Monitoring of profound block, it is not useful. It is clinically not used because we are applying 3 impulses and it can cause direct muscle stimulation sometimes. Now let us see the pattern. 750 milliseconds is the gap between the two, and after this 2 stimulation have been applied, after 12 seconds or 15 seconds, we can again apply 3 this particular kind of stimulation. Over here, you can see this is double burst stimulation 3:3. That means 3 impulses have been applied over here, and so it is 3:3. If in the second we apply 2, it is 3 will be 3:2. We don't require a control, right? And we calculate the ratio of the first to the second. In the case of a non-depolarizing muscle relaxant, you can definitely see over here the height. See, this is 0.2 ratio of TOF. The height is significantly different. 0.4, this height is increasing. 0.7, it has increased further. And 0.9, it is almost equal. So it is showing the recovery profile. Tetanic stimulation was developed by Sanoy in 1975 for detection of residual neuromuscular blockade. It is very painful and it is extremely useful for 70% receptor occupancy. It is the only clinical usages. It is used as a component of post-tetanic count. Why does the fade occur? In pain, it occurs because large amount of acetylcholine is released and it is mobilized also at the same time and released again and again and again at the neuromuscular site. But but the non-depolarizing muscle relaxants, they block the presynaptic release of the acetylcholine also. So we observe a fade after tetanic stimulation. Again to the table, tetanic, tetanus stimulation, supra or submaximal current, 30 to 50 hertz for 5 seconds, so it is extremely painful. We don't require a pre-relaxant control. Manual detection, definitely sensitive. There will be a definite fade which will be available for visual or tactile presence. Altered post-tetanic facilitation, interval is 6 minutes. Receptor occupancy 70 to 90%. Detection of sensitivity, yes. Monitoring of profound block, not useful. Post-tetanic count stimulation developed by Wibby and Morgenson for tactile and visual evaluation of profound non-depolarizing neuromuscular blockade that does not respond to train of pore stimulation. Response depends upon the degree of neuromuscular block, frequency and duration of tetanic stimulation, the length of the time between the end of tetanic stimulation and the first post-tetanic stimulus, frequency of single twitch stimulation. It has to be repeated after every 6 minutes. As you can see over here, coming to the table, this is the best guide for us. Supra or submaximal current, 30 hertz for 5 seconds it is applied. And 3 seconds later, a single twitch is applied at 1 hertz. So we don't require a pre-relaxant control. Extremely painful on the stimulation, very sensitive to manual detection. Subsequent of alteration of subsequent responses, it will be altered to be applied after 60 minutes. Extremely useful for profound block because it detects more than 90% receptor occupancy. Sensitivity of detection of subtle block not applicable. Now let us see the pattern over here. We have applied a 50 hertz stimulation, and after that we have applied the single twitch stimulation, and there is a fade in the case of non-depolarizing muscle relaxant. In the case of depolarizing muscle block, there will be no fade. But if after depolarizing muscle block, there is a fade, that means there is development of what? There is development of phase 2 block. This is the specific fade that you can see over here. Assessment of the response. Response can be assessed with the help of visual or tactile in the case of adductor polysis with the movement of the thumb, or we can use the recording devices. Recording devices can be based upon compound muscle action potential use or evoked contractile response. These are being used now extremely frequently. Isometric response, mechanomyography, non-isometric response, that is accelerophy. Mechanomyography is the gold standard. Why? Because we are keeping the muscle in a straight position, the hand, at 200 to 300 grams of preload. Our preload is applied to the thumb, which is the resting tension, and the force of contraction is applied into an electrical signal, which is recorded and displayed. See, over here, the thumb is into an influence of a pulley. Over here, there will be weight of around 200 to 300 grams. And as soon as this response is assessed, like the force of contraction is applied, there is an electrical stimulation which is applied over here. The force of contraction is assessed and it is converted into an electrical signal which is recorded and displayed. So the device will deliver a current, the thumb will move against a 200-300 grams of weight of resting tension, which will be amplified into an electrical response. And it will be an isometric contraction of the thumb. This is being used nowadays for objectifying the purpose. Electromyography, it is the oldest technique which is being used. It is based upon compound muscle action potential phenomena, which is produced by the stimulation of the peripheral nerve. Most of the devices nowadays are dependent upon electromyography. Sides, a learner, median nerve, larynx is there is an electrode where we can put it. This is for research purpose. Larynx and diaphragm where the electrodes are applied at T4 and T1 level at the back. Advantages, equipment is very easy to set up. Reflex factors influencing the neuromuscular transmission because it is extremely sensitive. And muscles that are not accessible to mechanical recording also, like the vocal cords, etc., diaphragm, etc., we can even assess them. Disadvantages, highly sensitive to electrical interference. The response does not return to the control value completely, and sometimes because of the electrodes, the muscles get directly stimulated, and we are able to quantify that the muscles are getting reversed, and we give the reversal, and in spite of that, there is inadequate reversal. This is acceleromyography. This is best in clinical usage in OT and ICU. It is based upon the Newton's law of motion. That is, force is equal to mass into acceleration. If mass is constant, force is directly proportional to the acceleration. It uses a piezoelectric ceramic wafer with electrodes on both sides, and they quantify the response. Sides, thumb, we are applying 5 electrodes over here, as you can see, for acceleromyography. Orbicularis oculi, corrugator superficially. Recent advantage is that three-dimensional movement of the thumb can be assessed because we are using electrodes at all levels. And this is the device that is used to deliver the current and at the same time keep the mass constant. This is acceleromyographic device, and it assesses the resting tension of the thumb and all the responses. Other techniques that are being used are kinemyography, cuff pressure modality, that is changes in cuff pressure due to the muscle contraction integrated into the blood pressure cuff. It stimulates the brachial plexus at humeral level. Compressobiography, phonobiography, that is the recording of sound of muscle contraction. Only advantage of phonobiography is that it can be applied to larynx, eye muscles, adductor pollicis, diaphragm, and eye muscles. It is under the process, and it can, if it is developed nicely, it will be the best portable device that can be used. Clinical usage. Check functioning of neuromuscular monitor. First of all, how to apply. Check functioning if neuromuscular monitoring is functioning or not. We have to choose the appropriate nerve muscle unit. For example, adductor muscles, we have to apply careful preparation of the skin. Apply positive electrode proximally to prevent direct depolarization of the muscle. Let me show you the diagram again. First diagram. Positive electrode to be applied first to prevent depolarization of the muscle. Okay, and coming back here. Apply positive electrode. Monitoring should be started after induction of anesthesia because we are using what? Supramaximal current, but before administration of neuromuscular blockage. Select supramaximal current, select appropriate method of stimulation, train of 4, double burst, post-tetanic count, whatever you want to use. Always use objectifying recording devices. Evaluation. How do we evaluate? First, intense neuromuscular block. Within 3 to 6 minutes after injecting the non-depolarizing muscle relaxant, there will be period of no response. That is intense neuromuscular block. Deep neuromuscular block, no response to train of 4 stimulation, but one response to post-tetanic count. To avoid diaphragmatic movements, we should target less than 3 post-tetanic count responses recommended. Moderate neuromuscular block, first response to TOF appears and there is gradual return of responses. See, level of block response to TOF, injection of neuromuscular blocking agent, fade response, intense block, TOF 0, PTC 0. Deep block, TOF count 0, PTC count less than 1. Deep neuromuscular block. Moderate block, TOF count 1 to 3. TOF count 1 to 3. And slowly there is a recovery phase. As soon as the recovery phase starts, repeat the dose of the non-depolarizing muscle relaxant if the surgery is continuing. Recovery from the neuromuscular blockage. This is an extremely important part. If TOF ratio is 0.4 or less, right, patient is unable to lift head or arm. Tidal value may be normal, but vital capacity and inspiratory force is reduced. Not a proper time. Not a proper time. TOF ratio is 0.6. Patient is able to lift the head for 3 seconds, but still vital capacity and inspiratory force are reduced. TOF ratio 0.7 to 0.75. Lift the head for 5 seconds, cough sufficiently, grip strength is still low. 0.8 and higher. See the point. When the TOF ratio is 0.8 or higher, only then vital capacity and respiratory force are normal. You can see the margin of neuromuscular transmission safety that is present in our body. TOF ratio 1 or higher, then the capacity to attain is 80%. You can see over here again, Basseter, TOF equivalent 0.86, normal grip strength, TOF equivalent 0.7, 5 seconds head or leg lift, TOF equivalent 0.6. What is the proper time to give the reversal? Now you decide. Train of 4 ratio again specifying the same thing, 0.7 to 0.75. Diplopia and visual disturbances is there. Decreased head grip strength, inability to maintain opposition of the incisor teeth. Tongue depressor test is negative. Inability to sit up without assistance in the recovery room. There is still facial weakness. Speaking effort requires an effort. Overall weakness and tiredness is there. This is the response which we see sometimes in the recovery room. When it is strain of 4 is 0.85 to 0.9, there is generalized fatigue and there is diplopia and visual disturbances. So you have to be very careful about residual neuromuscular blockage. What are the unreliable signs of reversal? Sustained eye opening, protrusion of the tongue, arm lift to opposite shoulder, normal tidal volume, normal or near normal vital capacity, maximum inspiratory pressure less than 40 to 50 centimeters of water. But more reliable, but still not excluding residual neuromuscular blockage are sustained tongue depressor test, sustained head lift for 5 seconds, sustained leg lift for 5 seconds, sustained hand grip for 5 seconds, and maximum inspiratory pressures. In the case of depolarization blockade, phase 1 block, no fade and no post-tetanic count will be there. That is normal plasma cholinesterase. In phase 2 block, it will be same as the non-depolarizing muscle relaxant. There will be fade and post-tetanic count will be observed. That means abnormal plasma cholinesterase. Reversal of neuromuscular blocking agent, a word about it. This table is important. Reversal with neostigmine we will talk about. TOF ratio at 0.9 or more. No reversal. TOF ratio of 0.4 to 0.9, neostigmine gives 0.02 milligram per kg. TOF count less than 0.4 or TOF count 2 to 3. We have to use neostigmine at a higher dose, 0.05 milligram per kg. TOF 0 to 1, delay reversal to the TOF count of 2. Got it? Reversal with sugammadex, there is a difference. No response to TOF, PTC is 0. We can give sugammadex because it just binds to the cyclodextrin bond and just removes the non-depolarizing muscle relaxant from there. It is not based upon the competitive phenomena of neuromuscular blockage. So 16 milligram per kg is the dose when we have to use post when PTC is 0. Between 1 to 15, we can reduce the dose of sugammadex to 4 milligram per kg. When TOF count is between 1 to 4, we can further reduce the dose to 2 milligram per kg of sugammadex. In a similar fashion, TOF ratio of less than 1, TOF of less than 0.9, sugammadex of 0 to 2 milligram per kg. This is when competitive assessment is there. Reversal when peripheral subjective nerve stimulator is available only, or quantitative neuromuscular monitoring is unreliable. No response to TOF, delay reversal to TOF count to 2. TOF count 2 to 3, give neostigmine to 0 to 0.5 milligram per kg. TOF count of 4 without fade 0.02 milligram per kg. With fade 0.04 milligram per kg. Reversal with Sugaba-Dex, no response to TOF, PTC 0, Sugaba-Dex 16. PTC 1 to 15, post-tetanic count, we are getting a fade, Sugaba-Dex 4 milligram per kg. So how useful is Sugaba-Dex? Now, clinically, how do we quantify it? Fast onset tracheal intubation, we have to use orbicularis oculi only. Single twitch or train of 4, target response, 0 twitches. We have to clinically give profound blockage, adductor polysis, orbicularis oculi. Which is the best, train of 4 or PTC? Both relaxed target response, relaxant dependent. Adequacy of relaxation for abdominal surgery, adductor polysis, nerve site of choice. TOF count, 1 to 2 twitches should be present at time to give reversal. Predicting reversible block, when no TOF response is present, adductor polysis again. Post-tetanic count, the best modality as relaxant dependent. Detecting reversible block, again, adductor polysis, TOF count, at least 2 twitches to be present. Detecting adequate neuromuscular function, again, adductor polysis side, double burst stimulation, there should be no fade. Excellent table. Now, what is the clinical use of neuromuscular monitoring and where we should definitely use it? When we are using long-acting neuromuscular blocking agents, severe renal and liver disease patients, myasthenia gravis, myopathies, lower or upper motor neuron lesions are present. Lengthy surgical procedures and when we are using continuous infusion of muscle relaxant. What are the limitations of neuromuscular monitoring? Greater impedance with perioperative hypothermia. Some patients may exhibit weakness between a TOF ratio as high as 0.8 to 0.9. Thank you so much for pleasant listening.